Alright, so in this video I'm going to talk to you about something called lip support. Now, lip support is one of the first things that you look at in your patient to see if they're a candidate for the All-on-4 procedure. So I'm going to go ahead and kind of guide you through everything with pictures from my AllonX book. So if you don't have my book, that's okay. I'm going to provide all the pictures that I'm going to need to explain the whole concept here. But if you want to supplement to this, and if you want to read about it in a more comprehensive way, you can get my book and kind of understand it a little bit better. Anyway, I'm going to talk to you about lip support. Let's get started in this video. I'm going to show you what my iPad looks like. Alrighty, so this is a patient who has just recently gotten their teeth extracted, right? And so right after you get your teeth extracted, everybody knows that you get some bone loss. And alright, so what I want to show you here is the pattern of bone loss. So everybody knows that after you get your teeth extracted, you have some bone loss. And the pattern in the maxilla and the mandible is a little bit different. So the maxilla, you can see it resorbs upwards and backwards, right? So all this starts to eventually kind of resorb back. And here you also have your sinuses. And so this area tends to widen up, get a little bit larger after you get your teeth pulled. So the area that stays relatively stable is this nasal bone right here, and this part continues to resorb over time. And now if we look at the mandible right here, so the mandible resorbs backwards and down. So this part resorbs over time, and it kind of gets lower and lower. But the portion that stays pretty much the same is going to be this basal bone right here. So this kind of stays where it's at, and then this part goes back. All right. So I know I tagged up this little model. All right. So I hope that part makes sense. Now, when you first get your teeth extracted, you have what's known as a tooth-only defect. So basically, you can imagine. Here, let's look at the iPad again. So this is somebody that has their full set of teeth in right now, but if they get their teeth extracted, so immediately the area that's missing is just the volume that was taken up by the teeth, right? So, well, obviously you can see here that this height is just the height that was taken up by the teeth. Now the teeth are gone, they're missing this portion, and so we could just call that, I guess they're missing this whole portion. So you can call that a tooth-only defect, right? You can see that these teeth were supporting the lips, right? The incisal edges of the teeth were supporting the lips and kind of plumping it up. And if those teeth are gone, the lips are going to sink in a little bit. All right, cool. So even though you only had a tooth-only defect when you first had your teeth extracted, over time you start losing more and more bone. And so now, say you've had 10 years of resorption or something, now you're not only missing the space that was occupied by your teeth, but you're also missing some volume that was occupied by your bone, because your bone's resorbed now. So you're missing some volume of bone, and you're missing some volume of teeth. And so when you have a defect that includes the volume that was occupied by bone and teeth, you're said to have a composite defect. So the first one was a tooth-only defect. Now this is a composite defect. I don't really like this terminology so much, but it is really useful to kind of talk about these things in a real basic way. So, all right, so when you have a composite defect, you're missing the volume that was occupied by bone and teeth. That continues to resorb. So you start with a minimal composite defect, and you continue along the spectrum until you get a moderate and then severe composite defect. So I'm going to show you what a severe composite defect. Let's check out the iPad. All right, so this is a severe composite defect. You can see that this person has had a considerable amount of resorption. And so see the bone resorbed and the maxilla resorbed upwards and backwards, and down here resorbed downwards and backwards. And now where their lips were supported, right? Their lips were kind of plumped out here because of the support from the bone and the teeth. Right? Remember the teeth were right here. Now the teeth are no longer there, and now they have a composite defect. So this portion of the ridge is no longer there. Right? And so now, now their lip sinks in. Okay, same thing on the bottom too, their lip sinks in. even though their teeth were originally right here or something. All right, so now the lips collapse. All right, cool. All right, so you can see that for a patient with a severe composite defect, if you restore their teeth back to where they were, so like teeth position doesn't change over time. So like ideal teeth position doesn't change over time. Everything else changes, but your ideal teeth position should not change. And so if you restore this patient with an AllonX, right, so their teeth are going to be pushed out back to where they originally should have been, they're not going to have that same lip support from the bone because the bone is already resorbed and now you're putting the teeth all the way forward. So I'm going to show you what that looks like. All right, so if you're putting the teeth right here and they no longer, actually, you know what? The maxilla is right here, so the teeth probably should have been like right here. All right, so if you're putting the teeth right here, I'm going to zoom into this. So if you're putting the teeth right here and there's a defect in the bone right there, so let's say your implants are going here. So your prosthesis is going to be sort of like that. It's going to be at an angle, right? And so this area right here, the lip is not very well supported. It kind of like sinks in right there. All right, and you're going to find the same thing on the mandible. I didn't draw this one correctly. The teeth is probably going to be more like out there. All right, and your implants are going to be back here, right? And so it's a pretty steep angle. It's a pretty steep angle from the implant platform to the teeth. And so this area, so you can see that this is where the lip was. So the new lip line would be like that. And it's going to have like a little sunken in appearance right there. All right, does that make sense? Yeah, and for the lower one, it'll be sunken in right there. That'll be called the mentolabial fold, or the mentolabial sulcus. And up here is going to be called the nasolabial sulcus. That's an NL. Nasolabial sulcus or nasolabial fold right here. So I'm going to show you some examples of what that looks like. All right, so take a look right here. This is a patient who has a severe composite defect and was treated with an Allon 4 for her lower. And so this is that mentolabial fold I'm telling you about, that if you restore the teeth to their, like, let's just draw, just for fun, how her mandible would be, right? So I'm drawing the shape of her mandible. Obviously, you know, we don't have a X-ray vision, but all right, maybe that's what her mandible looks like. And let's say we put the implants over here or something. Right, and then her teeth position is going to be out here, and now the prosthesis goes like this, right? And so that's why the lips. So the lips are supported like this now, whereas before they probably had more support. I mean, before she had all this bone resorption, she probably had more support like that, and now that's gone. So the lip sinks in right there. That's the mentolabial fold. And it's not just exclusive to the mandibular arch, right? Like I described, this happens in the maxillary arch too. So let me just, so actually right there, you can just see it right there. Happens in the maxillary arch too. So that's the first thing to know about treatment planning in these cases. So that's the first thing that you want to do. You want to find out, is this patient a tooth-only defect patient, a composite defect patient, and if they are composite defect, where along the spectrum of composite defect, so moderate or severe, where are they? If they are a severe composite defect, if they're open to the idea of having a removable prosthesis, I would nudge them in that direction. That's my personal preference. I think because it's easier to keep it clean, first of all. So you'll be able to keep an overdenture cleaner because you can take it out and scrub, versus if they have a severe composite defect, their prosthesis is a little bit taller, right? And so if it's fixed, that means they have to pull their lip back more and reach more. So it's a lot more work to keep it clean. And so I would try to suggest that they have a removable overdenture. If they really want a fixed hybrid, what I would suggest is maybe doing like a high water design if it's for the lower arch, a high water design, and just knowing that it's going to be a little bit more work for them to keep it clean, and also knowing that the forces will be a little bit less favorably distributed with a severely resorbed case if you're restoring them with the fixed restoration. So I guess biomechanically the prognosis is a little bit less favorable than with the overdenture. So that's pretty much it for lip support. Hope that kind of clarifies a little bit. So first thing is decide if your patient is a tooth-only defect, composite defect, and where along the spectrum they are, and use that to help navigate which treatment, or I guess which overall treatment modality works better, a removable or fixed.